I'm going to suggest that we begin with the understanding that there will be hordes flocking in at some point, straggling in from any libation or celebration they may have done last evening. So good morning and welcome. My name is Kevin McGirr, and I am a faculty member in the School of Nursing at University of California, San Francisco. And this morning, I have the privilege of welcoming you to our plenary for today, which is on working with vulnerable, hard-to-reach populations. I want to say just as part of the introduction that I am particularly gratified to be at the conference this year. And if someone was doing some research on the conference, which maybe someone is, I think we're finding more frequent mentions of the populations that I have spent my life's work with, and that is, it's particularly homeless, mentally ill, and substance-using populations. So that will be one focus of our plenary this morning. I think we have some quality work and research to share with you by a number of people from the US and UK. But last but not least, we'll also hear from a worker and an advocate from New Zealand who will talk about her work with the Maori community in New Zealand. So again, welcome to you. And so let me begin by, I want to do a couple of raising some questions for you to think about as we consider working with vulnerable populations. I think that many of the questions that I want to raise and pose to you won't necessarily exclusively fit with vulnerable populations. And if we think about vulnerability on a continuum, that many of my comments actually would apply to broader populations. You will hear a lot of data and some information about these populations, and I think we already know that particularly people with behavioral health challenges, by and large, smoke more, respond less to the conventional interventions, and also, but last but not least, suffer the greater consequences of tobacco use. So for me, again, this is a compelling issue. So let me move ahead with raising some of the questions. And the first question that I want to talk about is, have we adequately understood the meaning of this behavior, meaning combustible tobacco use, in this population? A couple of years ago, I did a small qualitative project in New York, and a couple of the subjects, independent of each other, said that, quote, "there's nothing like a cigarette." And I think we really need to understand the relationship, the culture, the reinforcement of this habit for people who are living and thriving or trying to thrive in these communities. And again, if we think about the converse, I am a former smoker, as I'm sure many people in the room here are. And of course, especially people in my age group, we stop smoking after many attempts, but usually without any help. And a lot of that has to do with, again, the culture of not smoking, that in particularly white middle-class environments, in the US, in North America, and probably much of Western Europe, the social interaction became a new peer pressure to change. And that kind of culture, I don't believe, is happening quite in the same way in vulnerable communities. Secondly, I think it's also important to really understand the emotional, the neurobiological, and we've heard some presentations around the benefits of nicotine. And again, there may be some specific meanings and biological facts that basically compel the relationship for people in various vulnerable populations to nicotine. I think we need to understand and continue to understand that aspect. And the last piece is the kind of more existential day-to-day meaning of tobacco use. And that's both the social aspect of smoking, but also we know that many people, particularly with mental health problems, they don't have much to do. So smoking becomes a very, very significant activity, something to look forward to, something to structure and organize their day. We've heard, and we will continue to hear, that this is a social justice and equity issue. I heartily believe that it really is. And of course, one of the problems with nicotine compared to other behaviors is that one doesn't get in trouble with combustible tobacco oftentimes for years to decades. So it hasn't always been a compelling issue. But I want to just kind of point out, making some comparisons, and this is not to denigrate the resources, the attention, and the focus on these other areas. So, for example, HIV and AIDS, particularly in the city where I live, has gotten a lot of attention, a lot of support, a lot of advocacy. Again, how does that compare to the support and advocacy for people in vulnerable populations and their tobacco use? Secondly, again, I'm not denigrating, but substance use treatment, and of course, when you're on the ground, it's never enough. There's never enough resources. But we have detoxification programs, rehabilitation programs, sober living housing, long-term recovery. There's quite an inequity in terms of the amount of support that government's public health is providing for tobacco intervention. We know that even monies that come from the Master Settle Agreement in the US do not meet the need in terms of helping people quit combustible tobacco. And the last, which we've had a lot of discussion at, and we constantly are discussing and battling this issue right now, particularly in the US, is the youth vaping issue. Yes, we need to provide attention for this issue, but how does it compare to the attention and focus and resource that we are providing to this population? So to give you another little factoid, if we look at the concern, the worry, the alarm, the alert about youth vaping, and when I started looking at comparing the damage that's done by underage drinking, 2,500 deaths, 2,500 deaths from motor vehicle accidents for underage drinking, just that one issue alone. Why aren't we alarmed and morally panicked about alcohol use amongst underage drinking? So let me say a few things about challenges ahead for researchers as well as the industry. So we really want to look at, and again, this applies to lots of folks, but is the sensory experience satisfying enough? Does the industry need to do continual work, and hopefully they are, around satisfying the sensory experience of new products for individuals, in these populations? Number two, are they user-friendly? And I'm concerned particularly for individuals who may have some issues around manual dexterity or cognitive impairment. Can they manage the oils, the coils, the charging? Those kinds of issues, really, I believe, if we're going to begin to distribute these products in these communities, we need to be thinking about those issues. Access, and of course, access primarily has to do with cost. Yes, we know, and probably many people here in the room who are vapers know, that to vape is going to be much more cost-effective than to use combustible tobacco. But the opportunity, the initial investment, oftentimes is a barrier for people in these communities. And last but not least, we're doing a lot of good work in researching in these communities, and we're actually giving them free product. But then we leave. What happens when we leave? So I want to just offer, my take on harm reduction, with this population around this particular issue. I've been involved with harm reduction much before tobacco harm reduction now for a couple of decades. But so this really derives for me, from my understanding of harm reduction. Number one, we radically accept that people smoke. There's no barrier to getting help, not even the expectation of change. We invite people into forums to begin to dialogue and engage with them around the issue of their combustible tobacco use. We give them a choice of options, and we want to be sure that we're flexible in providing those options, and including, because I talk to some people who say, I don't want to put anything else in my body. I don't want to have nicotine either. If that's what they want to do, that's the help that I should provide with them if they want to go cold turkey or they simply want to reduce. Are the interventions intensive enough, and are they sustained? Oftentimes known as behavioral support. I don't know that 4 sessions or 8 sessions are going to be enough. People may need a lot more longer-term intervention to really help them remain away from combustible tobacco use. And last but not least, I think it should be a no-brainer that access to whatever services or treatments or devices should be provided without cost. The last question, and again, it's a rhetorical question that I'd like you to think about, and that is, should we medicalize tobacco harm reduction? Now, I know that's probably controversial, and I will also share, I don't know where I feel about this, but I want to use the analogy with, quote, medication-assisted therapy, which we have in many countries around the globe. We have legitimized methadone maintenance. It's a medical intervention. Some people, I believe, will need nicotine for life. Do we need to, quote, legitimize that by making it a medical intervention? I don't have the answer, but something I'd like you to think about. So thank you. So let me pass this on to our first presenter, and that is Sharon Cox, who's done a lot of drug and alcohol work with the disenfranchised and is now working with various research projects around electronic cigarettes.